set the stage for our plenary session. You know, I frequently ask people, so what's the elevator speech? If someone asks me, you have one sentence to sort of tie in what people have said before and what's going to happen for the next 2 days. Our goal remains the same, and that's to have a workforce in health centers that looks like the communities we're privileged to serve. So without further ado, I'd like to introduce our speakers for today, from HRSA. I'm going to introduce them all now because we'll move forward with the slides as long as I've figured out how to move them forward. But we are very fortunate to have Luis Padilla, the Associate Administrator for Health Workforce and Director of the National Health Service Corps, Jim Macrae, the Associate Administrator for the Bureau of Primary Health Care, and Tom Morris, the Associate Administrator for Rural Health Policy. So Luis, I'll turn it over to you and do my best to move our slides forward.
Hi, Don. Thank you for that introduction. Thank you. I think, yep. There you go. Thank you very much. Thank you for bringing up the slides. And I think someone else is advancing them, so thank you for that. And Don, thank you. And I just want to follow up on what you just said. Having a workforce among health centers that reflects the communities you serve. And that's certainly a theme that you're going to hear in my remarks today, and something that we've been working on for several years. So before I get started, I just want to highlight some of the points that I'm going to remark on today. One is the ARP funding, what that means for health centers. The other is the opportunities that exist in terms of building the capacity of health centers to do more education and training. Certainly around the efforts that we partnered with Jim and our colleagues at BPHC around the Health Professions Education Training Program. And then look ahead, what have we been able to do? What do we see as the opportunities and path forward to build that capacity of education and training within health centers? And what do we see as the opportunities and some of the challenges? So thank you. And again, I'd like to thank NACHC for this. Ever since this started a few years ago, I remember in Alexandria when we had this first summit, it really, for us, it provides an opportunity to talk with an important stakeholder like NACHC and others, the PCAs, the NTTPs, all of the stakeholders that are really focused on workforce. And I just want to say again, thank you to NACHC for having this biannual workforce summit. If we can go back to the previous slide, please. Oh, we're going forward, and go back. There, all right, one forward, thank you. Next slide. Thank you. So again, and I think all of you have heard me say before that our mission at BHW is to improve the health of underserved populations. And we do this by strengthening the health workforce, most importantly, connecting skilled professionals to communities in need. And over the last several years, we've really levered and addressed and built the capacity to develop this continuum of education, training, and service. And as I've said before, that last piece is probably the most important part. It's not enough to train all these individuals, these students, these trainees, residents, if they're not going to areas where they're most critically needed. So that remains our mission, that remains our focus, and I think you're going to see that reflected in the rest of my remarks. Next slide, please. So as we look at our focus areas, our departmental priorities are certainly around COVID and the response and the ongoing response, and more particularly about an equitable COVID response. And the administration has certainly been clear in that efforts. But we're also challenged with addressing maternal and child health across the country. And in addition to that, behavioral health. So these are the priority areas that our Bureau are primarily focused around in terms of workforce. And when you drill down a little bit more, we're specifically focused on behavioral health and the larger component of community health. And that entails several aspects of workforce, which I'll go into, but those are the two, if you were to bucket, large focus areas for BHW. But we recognize that there are cross-cutting themes across these areas. Provider resiliency, and I heard earlier in the opening of the session, the importance of recovery. And we certainly have been preparing for that because we understand that the pandemic is going to wane. And for the last year and a half, the impacts of the pandemic for the workforce are going to become quite evident. As already been mentioned, provider resiliency, burnout, wellness is front and center in our work. And we view this as a cross-cutting effort because we have many programs that have the ability to lever this very important theme of workforce. And obviously, health equity, and a component of that is diversifying the health professions. And I think Don can speak to this just as much as I could in our efforts over the last decades to try to better diversify the health professions. And I think that, as Don said, if we're going to have any hope to have a workforce that reflects the communities we serve, we have to begin the arduous process of diversifying the health professions and looking at ways to do that, not in the traditional ways that we've done that, but other more creative community-based ways that incentivize, encourage, support, and achieve the diversity among workforce professionals and allied paraprofessionals that we desire, that we think is needed to serve these communities across the country. Next slide, please. Sarah, we can go to the next slide. Thank you. So our budget typically is around 1.6 billion, but our budget has exploded, doubled in size as a result of the American Rescue Plan. As you can see here, we have a number of programs that we historically administer and support workforce across the country, but this addition of 1.55 billion as a result of the American Rescue Plan has dramatically changed our budget landscape. And it has us focusing on things that we haven't had the ability to focus on before. And we think that while there's challenges in this funding and these funding opportunities, enormous opportunities for workforce development, certainly among health centers. So a little bit more about this budget on the next slide, please. So I think all of you are aware that 800 million is going additional funding for the National Service Corps. We've already begun the process of deploying that funding. Our loan repayment application closes on the 27th. Last read, we had over close to 13,000 applications that were in process. We hope, as providers are scrambling to complete that, that we'll meet our target and we'll be able to expend the money that we targeted to expend this year to have really the largest field strength ever in the Corps' history. We've closed out the scholarship program. We received over 2,000 applications for what will be nearly 800 scholarship awards. This is significant. Whereas traditionally we only provide about 200 scholarship awards. We're going to quadruple that this year and next year. That is an infusion of scholars down the pipeline, whereas the loan repayment program is really incentivizing clinicians to work and stay in those areas. The scholarship program creates that pipeline, and it is a mechanism to diversify our health professions through that program. Our Nurse Corps program received 200 million additional dollars. With that, we're going to be able to focus on maternal health. We're going to be able to focus on public health and provide a means to provide support to those nurses that are critically needed, not just in critical shortage hospitals, but hopefully health centers as well. Next slide, please. So I think one of the most exciting things that's come out of the ARP funding is the additional funding for the Teaching Health Center GME. This is the model that BHW uses to tailor its other workforce programs. This is a program that's rooted in the community, that's focused on primary care, focused on interdisciplinary, interprofessional training of residents, and every resident that we graduate from these programs is above the CMS cap. That means we have additional primary care, mental health, psychiatry providers, and oral health providers as well, because we do support those disciplines through this program. So with this, what we're going to see is we'll be putting funding out for the planning and development of new programs. We're going to provide funding for new and expanded residency programs. Those FTEs that we haven't been able to support within the existing awardees will be able to do, and then put on a new competition for to increase the footprint of this program. In addition, we'll be deploying a planning and development technical assistance center to support these new programs, both in the planning and development and those new ones that come on board. Because we understand one of the most pressing issues for this program is long-term sustainability, and it's going to be one of the major focus areas of this technical assistance center. Next slide, please. So a lot of talk about resilience on this call and on many other calls that I've been on. And we're excited about the opportunity that the ARP has provided BHW HRSA to provide support, not only at the individual level, because Congress has appropriated this $120 million to support resiliency, wellness, reducing burnout, suicide, substance use disorder among providers, but also supporting organizations to make that cultural change. We know and we recognize that many health centers have taken great steps to support their workforce. And we believe that as eligible entities for this funding, you'll have opportunities to further support those efforts and expand and build on those efforts and hopefully create new efforts to support the workforce going forward. Next slide, please. So mentioned before the U.S. health workforce trends, and these trends were occurring before COVID. There has been a growing demand for health professionals and allied professionals, and at the same time seeing a shrinking supply of that workforce. And certainly, as you all recognize, an unequal distribution, particularly in rural and underserved areas. But as I mentioned before, in the area of diversity, we've seen a long-standing trend as well, a lack of diversity among health professions training programs. And this is another trend that is worrisome in terms of health equity, in an area that we're most intently focused on in the years to come. Next slide, please. So some of the strategies that we've deployed over the last several years, we've been recruiting and encouraging recruitment from students from the communities that they serve and will train in and serve. We've been training students in rural and underserved areas. And most importantly, we've been supporting community-based training. And for those of you who follow our funding, who have come in and applied for our funding, I hope you've seen this consistently in our funding opportunities. The paradigm of training our trainees in large academic centers, not tied to communities that they ultimately serve, needs to change. And that's the effort that we've undertaken for the last 5+ years. We've also been leveraging our loan and scholarship programs, and I hope you've seen the connection now with THC GME in the National Service Corps, addiction medicine fellowships in the National Service Corps, and we'll be looking at ways to tie in our nurse practitioner residency programs to give them priority awarding through the National Service Corps as well in the years to come. Now, fortunately, the ARP has allowed us the ability to sort of not have to worry about those priority awarding, because we believe we'll be able to fund nearly every eligible applicant that comes in for our LRP funding this year and next year. And to this last area of integrating behavioral health, oral health into primary care, this is what we see, and most interested to hear Jim's perspective and Tom's perspective on how we can further integrate behavioral health, oral health into primary care throughout health centers. Next slide, please. So I think one of the best things we've done the last couple of years in this area, and I just want to give a kudos to Jim and his team for partnering with us and supporting us and leading the way here, is providing funding for the Health Professions Education and Training Initiative. And while we see this as a pretty significant data collection, it's going to pay dividends. And I'll just take us light years, 3 years from now, what we'll see. Through this effort, what we want to see is more health centers propping up education and training programs. That's really what this is about. The data that's been collected now in a whopping 73% response rate amidst a pandemic. Imagine that. Every one of you who took the time to respond to this survey, this tool, said this is important. We have to get a better understanding of where we are in terms of workforce development. And kudos to all of you, the over 8,200 responses here. It's going to give us valuable information to better target our resources, better support PCAs and partners to help health centers build that infrastructure to do more health education and training. So we're going to, I believe that we're on track to release that data as of July to PCAs. And then health centers, HRSA will be receiving that information as well. We're going to begin to look at that information and start to make changes in our programs based upon that, identify those gaps, and better tailor our funding opportunities in the future. Next slide, please. So again, these are the outcomes that we're hoping. I would just draw your attention to the very last one, because I think that's the most important part. Boost the number of health centers with education and training programs. If we don't utilize this information in a way that assists your organizations in doing more education and training, building your own, growing your own, educating your own, trading your own, then I don't think we've really fully leveraged the opportunity through the HPET initiative. Next slide, please. So from a data perspective, if you look at what we've been doing in the last 6 years or so, you've seen a slight, steady increase in the number of training sites and medically underserved centers in primary care. Where you have not seen that steady increase, and I'm sure Tom is looking at that yellow bar as well, it's been fairly flat. So we hope to have more investments in this area to support organizations to have more rural rotations, more exposure to rural areas, to again, incentivize and encourage and expose those individuals to that environment. But I say the promising news is here is we're seeing an increase in the number of sites that are doing this already. And we think that through the efforts of the HPET, these numbers will increase. Next slide, please. So the road ahead for us, where have we been? We've revamped our training programs to emphasize academic and community-based partnerships. And where are we now? We've been advancing the recovery now with this $120 million to focus on provider resilience and well-being and mental health. We think that's going to go a long way. We continue to address health centers' readiness to become training sites and learning what they need. And we're going to continue the effort to link our health professions grant programs to our loan and scholarship programs, because we believe that's key to driving that workforce where they're needed the most. So where are we going? We're going to continue to advance health equity. This is a major priority of this administration, and in particular, provider health professions diversity through our programs wherever we can. We'll continue to look at our grant programs to add any flexibility in those training requirements to support community-based training and we're in those facets. And we're going to continue to focus on expanding our care teams. As I've said before, we simply won't be able to achieve our aims, BPHC's aims, your aims, unless we look at the broader view of the team composition, the model of care, and how health centers in particular are using allied paraprofessionals to reach those outcomes. Next slide, please. So those opportunities, as I mentioned before, telehealth, and just a word on that, I know Tom will probably speak a little bit more on this. COVID has made us realize that the experiment of telehealth is possible, but it hasn't been done without pain. I don't believe that it's facilitated or reduced clinician burnout. I don't believe it's improved clinician well-being, but we have seen some positive lights, particularly around mental and behavioral health. So we're going to continue to work with our partners to see where's the road ahead for telemedicine, telehealth, and in particular, where do we see opportunity to leverage that technology as it relates to training, particularly in remote areas. Again, clinician well-being is a major focus of ours, as well as maternal health, as the administration has laid out. But there are challenges. COVID slowed down our training ability, and you saw it in each one of your centers. You either halted or slowed the education and training of students or residents in your centers because of the pandemic. That machinery needs to be revved up, whether it's through our efforts of the HPET or through other efforts to assist health centers to now get the machinery going. What have we learned? What can we do better to improve that infrastructure to do more education and training? Let me stop there because I've said a mouthful and I want to give enough opportunity for Jim and Tom. But I just thank you for the opportunity to share what we're doing, what we see as the path forward in terms of workforce development. And again, we value your partnership and welcome the discussion. So thank you. Back to you, Don.
I guess I'll jump in. Go ahead.
We'll swing it over to you. The thing I forgot to remind people in the beginning is if you do have questions, please put them in the chat, and we'll get to those in a Q&A section at the end of each presentation. So Jim, back to you.
Great. Thank you, Don. And it's great to be here with you all. And of course, I have to say good afternoon and good morning to those out now in the Midwest and the West Coast. I'm so happy to be here today. And really talking about a topic that is front and center in my mind in terms of when I think about the health center program. It is the workforce. And when we talk about workforce, for me, it's not just the provider workforce, but it's everybody from the frontline folks who are checking people in all the way through our community health workers to all of our clinical and support staff, our admin staff, the board. We really have to make sure that we do everything we can to support our workforce. And it has been an incredibly challenging year for all of us, both personally and professionally. And I think taking the time and still having this summit, I just want to congratulate the sponsors and everybody who's participating, because I really do think this has to be our focus going forward, not just right now, but really over the next several years if we're going to build back what we want to see, but even more importantly, build the future of what we want health centers to become and really lead, I think, the country in terms of where we could go. So really timely, really happy to be here, and so glad to be a part of today's session. Big shout out to Luis for all of his work. I don't think he gets enough credit for really the push that he has done to really encourage, of course, the focus in primary healthcare, but honestly, a focus more in community-based care and specifically in FQHCs. There are a lot of forces, as you know, in the world that push against that, but to really push in primary care and push to underserved communities, I think is critically important. And a huge thanks to my colleague, Tom, for just the continued focus around rural and making sure that as we're thinking about all of our different programs and activities that we really are taking into account the needs of our rural partners and communities and the patients that are seen, which often have very different needs than what we have in an urban setting. So big thanks to both my colleagues. If we can go to the next slide. So I think a good place for us to start, and I'm going to be honestly very interested to see what this looks like in 2020, given the pandemic. But this does give you just a baseline on the overall workforce in the health center program. And again, this provides the full listing of the 252,000 or so folks that are employed in our health centers nationwide. What I would also just point out is the significant increase that we've seen in certain disciplines in the health center program. Most of these I know are not surprises, but I think it's just important to again point out, we've seen, as you can see, a big jump in our nurse practitioners, almost 19% as compared to the overall percentage increase of 13%. But we also have seen rapid increase in our mental and behavioral health services. So both on the mental health side, psychiatrists and psychologists, other mental health providers, but also in the substance use area, we've seen a significant increase there. In addition, we've actually seen a big increase over the last several years around vision care, which is great. What we are not seeing as big an increase in, although everybody talks about the importance of it, really is in that second to last category around enabling service providers. So I think we all have really seen the value, especially with addressing some of the upstream influences of health and community health workers and other providers, outreach workers, eligibility assistance workers, transportation, translation, case management, all the things that we all acknowledge are really important. But honestly, we haven't seen the growth there. And we, from where we sit, are really looking at what we can do to better promote that particular category of providers. But I would just encourage you, especially in this summit, to think about what we can do to better support those types of providers, staff in our health centers, because the argument that I think we've now been able to make is that they not only make an impact on access, but they also make an impact in terms of quality and are absolutely able to help us when we have public health emergencies and other activities. So that's one challenge I will just put forward to you all. If we can go to the next slide. I think another big challenge for all of us is really taking a look at where our workforce currently is. And so, we've been working on this activity to actually do a national survey of all of our health center staff to get a baseline. When we started this, we did not know the baseline would be in the middle of a pandemic. But in some ways, I think it actually will help us sort of see where we are. And more importantly, what are some of our strengths with respect to our workforce? What are some of our challenges? And what are some of the opportunities for us to be able to move forward? We were concerned prior to the pandemic about provider well-being, staff well-being, the pandemic, the social upheaval, the unrest, the racial inequalities that we're seeing, the social justice impacts have all had a significant impact on our staff. And really getting a baseline of where we are, we think is important. But even more importantly is that piece where we want to get groups of health centers to actually work together to figure out what are the best approaches in terms of moving forward with our workforce. And again, I think today's summit can really help provide us with some insights about what makes sense from where we sit to be able to provide support to our current workforce in terms of their well-being and their engagement and addressing issues of burnout. So just would encourage you as we start to think, of course about recruitment, of course about retention, but what can we do to support our current workforce? All right, let's go to the next slide. One of the other things that we've continued to stay focused on, and again, we created a baseline last year to get a sense about where we are with respect to health centers providing that training and education opportunities. And the good news is that it was actually, to be honest, a little bit better than I had anticipated. So close to 70% of health centers report that they're involved in some level of education and training. You can see that, the vast majority are training sites, which is fantastic. But we're also seeing an increasing number who are becoming sponsors. And you can see, of course, a lot of it naturally falls in the medical realm. But again, I think one of the opportunities for us is really what can we do more of around oral health, mental health, vision, and some other professional training. as well as, again, those enabling services and support for those folks in terms of their training and experience. Because as Louise said, we know that if people are trained in a health center, they're more likely to end up in a health center, and they're more likely throughout their career to be able to provide services to the underserved populations in this country. All right, let's go to the next slide. I did want to just touch on the impact of COVID-19. Touch on, that's a bad way to say it. It has had a devastating impact on all of us. I have shared with my own senior staff just the trauma that folks have experienced, even where we sit in the federal government, let alone on the front lines where many of you have been with your staff. It has been a major impact both on us personally as well as professionally. In the health center program, we have lost a number of staff. We have literally had a number of staff who have passed away as a result of COVID. We've had family, we've had friends, and it has a devastating impact on the health center, its morale, and to be honest, just the support that people feel for one another. On top of that, you can see we had almost 42,000 staff that tested positive. That's a significant disproportionate impact, and not unsurprising, but definitely had an impact on our health centers. The good news in terms of where we are is that we have gotten to a place where almost all of our health center staff have been vaccinated. In our most recent survey data, sort of cumulative, we're up to 233,000. And we have about 250,000 overall. So that's really good news in terms of the staff that have been vaccinated. We continue to hear, however, that staffing is a challenge in terms of administering the vaccine. The good news is actually with just last week's survey data, so this slide hasn't been updated because we literally just got it, it's actually dropped to number 2, but unfortunately vaccine hesitancy is raised to number 1, which I think we all anticipated getting to at some point. And then honestly, something that's been really positive, but definitely is going to challenge us to think differently is really new ways of providing care. So with vaccinations, we've been strongly encouraging health centers to go out into the communities much more, use mobile vans, create pop-up clinics. How do we continue to do that going into the future? And of course, the whole pivot towards virtual healthcare. And what does that look like going forward? And hopefully, many of you saw our recent funding opportunity that we just put out for $25 million, or for $50 million to support 25 health centers. The idea behind that is really to get a small group of health centers together, figure out what the future is of that balance between in-person and virtual healthcare, and what makes sense both for the providers as well as for the patients, as well as within the communities. And how do we make sure that by moving in more of this direction, we don't create a further digital divide, but how do we support all of our staff and patients in this movement towards virtual healthcare and what is optimal? Let's go to the next slide, and this is what I will end on, which is really thinking about the future. So sort of challenged you to think about what we could do with enabling, and challenged you to think about what we could do with training, challenged you with what we can do in terms of our work, just going forward together. Actually, if we can go back to the next slide. Sorry, go, whoa. Can we hop back to? One of the things, oops, whoa. There we go, fantastic. So one of the things that we've been challenging ourselves with is really thinking about what do we want to see in the future in terms of the health center program. There's been a lot of discussion about potentially significant growth in the program. And so we've been honestly spending a lot of time thinking about that. Not that we've had a lot of time, but we just felt like if we don't start to think about and consciously make decisions about what the future looks like, it's just going to happen to us. And so we really wanted to take some time to do that. And I think, as many of you know, we've been asking a lot of questions of you and others about the health center of the future. And what we've been really trying to do from where we sit is how can we support it best in the Bureau of Primary Healthcare. So what you see on this slide is really a set of 4 vision statements and then some goals underneath each of them. And I just want to spend the last 5 minutes talking about these. So the first one is that we really want to get to a place where every high need community in this country has access to the health center model of care. And that really is a recognition that the health center model of care does make an impact on people's access to services, but it also makes a difference in terms of the quality of the services that they receive and ultimately their satisfaction with those services. And one of the goals that we have is how do we do a better job from where we sit to make sure that all communities that are high need really have access to that model of care. And so we're looking at how can we do a better job of identifying where those needy communities are, and more importantly, how can we support those communities to actually develop a health center site that can provide those services. The second vision statement really relates to something that I've heard many of you all talk about, which is how do we make sure that folks have access, patient-centered access to services that address both clinical and social barriers to health. And we consciously said to health and not to health care. So how do we make sure that health centers are providing that sort of full complement of services that are patient-centered and really provide for us, in terms of our goal, that comprehensive range of services? And one of the things that we've been looking at and doing some work on is really to look at what's the gap between where we are today and where we could be in the future. So we've been looking at, for example, what's the gap right now? We're providing mental health services to about 8% of our patients, but recent SAMHSA surveys have said that in any given year, about 1 in 5 people requires some type of mental health service. So we clearly have a gap in terms of what we're able to provide in our health centers. Same thing with substance use disorder services. We're at about 8% is the need, and we're right now at about 1% of our patients are benefiting from substance use disorder services. So there's a clear gap there. On enabling services, we're at about 7 or 8% of our patients are receiving enabling services. But if you just look at our patients that have limited English proficiency, that's almost 24, 25% of our patients have need for those types of services. So we clearly have a gap there. And one of the things we're trying to figure out is how do all health center patients have access to that full range of service that health centers can provide, and what can we do to help support that? The third vision statement really, I think, recognizes that health centers have been recognized as really leaders in terms of health equity, really reaching into the communities where people have a distrust of the healthcare system and can be leaders in terms of delivering that high quality care that not only improves health outcomes, but also addresses health equity. And so how can we do a better job to support that kind of work? And really the way we've been thinking about it is how do we support both the use of evidence-based practices, but also innovative models of care to improve those health outcomes, reduce health disparities, and advance health equity. So we've been really thinking about how we can create a true quality improvement fund that could help support that type of activity. And one of the areas we've been honestly thinking about is what could we do in the workforce space that could be really innovative for all health centers across the country. And then finally, we want to make sure that health centers are operating those state-of-the-art facilities that really do optimize service delivery in medically underserved communities. So we want to make sure that the services are the best that they can be, but we also want to make sure that the sites and locations where people are receiving care, again, whether that's in person or virtual, are of the highest quality and accessible for our patients. Let's go to the very last slide, which, and this is a shout out to our colleagues at NAC, but really all of our national TA partners who have done just a tremendous job of providing information that we hope is beneficial to our workforce. It provides a lot of information in terms of different resources that are available. It is a resource that we go to quite a bit when people ask us different questions. And we would just encourage all of you all, if you haven't already, to make sure that not just you, but your staff are actually aware of all of these different resources that really are beneficial, especially over the past year. So just a big shout out to all of our folks in the Clearinghouse for all of their great work. And with that, I will stop and turn it back over to Don to introduce, I think, Tom Morris.
Jim, thank you very much. And thank you for bearing with me as my fingers hit the wrong buttons, but I think we got on the right slide. So we're ready to go. Tom, we'll head out to rural America.
All right. Thanks, Don.
Yeah, sure we will.
Sometimes it's a little bit longer drive to rural America, so, but it's well worth it.
Okay, bear with me here. I thought I hit the.
All right.
Okay, there we go, Tom.
All right. Hey, thanks so much, John. I appreciate it. Anyway, thank you for the opportunity to be part of the panel. I really do appreciate it. And a big nod to Luis and Jim. I think they've done a great job. I think Luis of sort of setting the big picture, and then Jim really putting it into a health center context. And I appreciate your attention, their attention to rural issues, in all the work we do. It just makes things a lot easier, particularly, when you realize that over this course of the last, 10, 20 years, the footprint of health centers has grown so dramatically. They're certainly in parts of rural America that they weren't in when I began my career. And so, I really appreciate that attention to rural issues. I'm going to touch a little bit on the pandemic and how it played out in rural America, some of the workforce things we're doing, and I'll touch a little bit about telehealth, but I know you have that session later today, and then some other resources that help. And I would just sort of also just really echo Jim's point about looking beyond workforce solely in the clinical context. I do think the coders and the billers and the IT people, they don't get a lot of attention, and yet without them, it really makes it quite difficult. Next slide, please, Don. All right, so, thinking about the workforce issues, the pandemic issues really loom large, because I think there are some things that are universal that happened in terms of the pandemic for rural and urban communities, but then there were some unique rural aspects too. And I think the key difference was sort of the trajectory of it. I mean, there was a delay in its impact broadly in rural communities. It certainly seemed to affect cities first. And I think the key lines you can look at here are the green line versus the purple. And so there was this initial sort of delay of it hitting rural America, but then once it did, it hit with a big force and is continuing. You're continuing to see higher mortality, as a result from it. And so those are some of the key differences. And I think we have to factor that in when we're talking about its impact on workforce. The commonalities, though, were, the shortages of PPE, the stress on clinicians, and then the concern about the long-term impact on being able to keep the clinicians you have or recruit people for the future. And given what we know historically about the challenges in rural communities, attracting and retaining their workforce, this is going to be a real steep climb coming back. Next slide. I was struck by, an article I'm sure folks saw in the New York Times earlier this year, sort of talking about all the issues that Jim and Luis have already brought up, and that was the stress on the workforce. And it had a quote from work by Don Pathman at UNC, because he had a survey in the field right at the time this article was out. And so, was able to bring to bear some of the things he was seeing in some of that survey work he did about the stress this was causing on the workforce. And I mention it because Don does a lot of survey work that includes health centers in it. And many of your PCOs, your PCAs and the state offices will all have access to this data. So it may be that it may help you in terms of thinking through what it looks like individually. And I'm sure they'd be happy to break that out for you. I think what's clear to me, I think it's probably true for you all too, is that we're just entering uncharted territory here. We don't really have a historic parallel to draw from to think about what the impact might be here and what the long-term aspect will be. But I suspect that, whatever they are, you're going to feel them first. And because of your history of being creative and collaborative, you'll be the ones that figure out, workable strategies moving forward. Next slide. So what are we doing? I mean, I think there are things that can be done. I applaud Luis for his work in terms of always being willing to take a lot of his notices of funding opportunity and revisit them each year. They don't just come out on a conveyor belt. There's always a lot of thought about what's going on different this year that we want to bring to bear as BHW writes those grant guidances. And I know that in a lot of ways we've learned from things that have gone on in the health center world. I think about I don't think we'd have a rural residency planning grant program right now if it wasn't for the trailblazed for the teaching health center program and sort of proving that you don't have to be in an academic health center to train a physician. And so that made it much easier to make the case that we could expand residencies into rural communities. Because for years, since they imposed the cap in '96 on Medicare GME, there's been the authority to start new rural residencies in rural hospitals. It's just nobody was really taking advantage of it. And so we were happy to then get the funding to create new rural residencies. And the concept we had was Not that we would continue funding the residencies, we would just pay to get them started, to get them through the accreditation process, to create the opportunities for them to get there, and then to be able to then tap into Medicare mostly, but to some extent Medicaid and/or state revenue. And so we're getting ready to award another 9 of these grants. It's exceeded our expectations in terms of what we've been able to produce. We knew that we'd get a healthy dose of family medicine, but we've also got internal medicine. And then the real surprise has been 5 psychiatry programs, which I think, is sorely needed in rural America. And so it's great to sort of see these folks out there. Next slide, please. And this has been made easier by the Consolidated Appropriations Act that passed in December, because it actually broke open the GME box for the first time since 1996. There are now opportunities for a small expansion of residency slots across the nation. And we worked with CMS on this. Both BHW staff did a great job of providing them with HPSA data so that they'd understand how to use that. And there's a set aside for rural, a set aside for underserved, and you'll see that it's out in the proposed rule status right now. But for the communities that health centers are in, and especially in rural America, there's going to be an opportunity for residency expansion in that regard. They also created more flexibility so that we could grow the number of rural training tracks. This is a model very much like the Teaching Health Center program, in the sense that you do 1 year in an academic health center in the rural training track, and then 2 years out in the community. And then they've also created flexibility, because for Medicare, what happens is, your cap is calculated the minute a resident walks through the door. And for rural hospitals in particular, even if they were only there for a month 10 years ago, that started the clock on how Medicare counts it. And so it really was a limiting factor on how many places could take advantage of the flexibility to start new programs. And so, this is the first time that they've opened up Medicare GME in a long time. And I think there are opportunities for health centers, but there are also opportunities, for rural hospitals also. So next slide, please. All right. The other thing we fund, and you all may be aware of this, but the Rural Recruitment and Retention Network, we work with about 46 or so of the states, a couple of tribal nations, basically to create a point of contact at the state or tribal nation level, to help link providers who are looking for opportunity to practice in rural America with rural communities who are seeking those providers. And there's a broad diversity in here. Some of the states, it's mostly posting jobs, but in some of the states, they really take a very active approach, community development, really working with people throughout the life cycle of recruitment and retention, realizing that the retention strategy and the recruitment, they never really end. You're constantly re-recruiting to keep them there. There are a lot of great tools and resources on that website. If you're not familiar with it, or if you want to know more about how engaged your state is, please reach out to them. I think they can be a really important tool. There's no one perfect solution to the challenges we have. So Luis is doing a lot of neat things with data on his website. We've long supported the Rural Recruitment and Retention Network. Obviously, NAC does a tremendous amount of work through the cooperative agreement on health center specific workforce issues. I guess the point I'm making is that you should avail yourself of every single resource that's out there. And this is just another one to add to the list. Next slide, please. We talked a little bit about telehealth, and I did want to mention it just because, as Luis noted, we went from a period where we've been talking about the potential of telehealth for years to a situation in which, because of the stay-at-home orders, that we had to move to telehealth in a very real way. And certainly, we saw that first and foremost in the health center world. Jim's data was compelling in terms of how many health centers were able to quickly pivot to that virtual model. But, you can look at some of the data that's available in Fair Health, which is a combination of both public data and private sector claims data. And they show dramatic increases. But then we just saw some data come out from CMS last week, about 2 weeks ago, actually, about Medicaid data, and it mirrors what we saw in the health center world. But I think the big challenge for all of us is what happens next. There's obviously a reason a lot of this happened was because of some of the flexibilities that were allowed during the public health emergency. And one of the challenges, I think, both for the department, the administration, but also for the Congress, is which of those are going to continue, and how are they going to do that? And it's vitally, I think, important that we have some clarity on that moving forward. And certainly people are talking about it. But if it was easy, it would have been done long before we had a public health emergency that forced us into it. And so I think that's one of the big challenges coming forth is how do we figure out what the path forward is so that we can build on this moving forward. Next slide, please. So, you know, the one point is there's a lot more resources out there. Jim mentioned the funding they're providing, but one of the things that we realized we needed early on in the pandemic was that we needed a central website at HHS that could sort of link all this together, that could be an initial landing spot for folks. And so now we have that, and there's we're going to build that out moving forward, because what you saw in the health center role was sort of echoed across the board at HHS. We had an expansion of pediatric mental health in our maternal and child health bureau. Luis and his programs really did what they could to leverage telehealth. We provided a significant increase in the amount of technical assistance we have, and we now have new portals that make it easier to bring people on from a licensure standpoint. So, I encourage you to look at all those resources, because we're trying to make it easier for folks to go through that licensure process, realizing that we have to find that balance between protecting patient safety and recognizing the sovereignty of the state licensure boards, but not making it a barrier to bringing somebody on to provide care virtually. And so that's one of the things we'll have to figure out moving forward. But there, I think the other issue that we're going to have to deal with very quickly is there's still broadband gaps in this country. And while there's a lot of money that's been appropriated in the past year to do that, our track record has been somewhat checkered in terms of our ability to really target that funding to the areas of greatest need. I'm hopeful, but we really have to pay a lot of attention to that. And then, I think the other big question is, even if we addressed all the reimbursement issues moving forward, and the licensure issues, there's the operational aspects. And I think Luis hinted at this, and that is, it's not plug and play. You don't just, turn the telehealth equipment on and it works magically. There's a lot of different ways and different models of doing it. Do you expect a clinician to both see people both virtually and face-to-face? And if so, how do you do that in a scheduling way that's efficient and works for both the clinician and the patients? And I think we're just going to have to try those things out and figure out what works best. On the other hand, maybe it's best to have some clinicians dedicated just to doing the virtual care and others that focus on face-to-face visits. But this is a new territory for us in terms of figuring out, and certainly consumers are used to it now big time. So how do you build a system that works as well for patients as it does for clinicians? And what does that do for your overall workforce anyway? Next slide, please. Two other things I just want to mention in closing up. One is, as we think about workforce in the rural, there are broader challenges happening that have spillover effects on health centers. We've known that we've had more than 130 rural hospitals closed since 2010. And while we haven't had any for this year, which is great, the fact is we've had a lot of these closures. In some cases, they're complete closures where we have a huge gap in services, but in other cases, it's a partial closure and there's still some semblance of healthcare in that community. A lot of times that falls to the community health center that's either nearby or in the community. And that puts extra stress on it. But I do think that there are new options coming down the pike. One of them is that they created the new rural emergency hospital designation. This would be a hospital without inpatient beds, but would have emergency care and ancillary care services. Rulemaking for that will happen next year. I think we'll have to see how much of an uptake there is for this. And then I think we'll have to think about what this means in those communities and what it means for health centers. Right now, it's only open to hospitals, and not even closed hospitals. It's hospitals that want to make that conversion. But as you know, anytime they pass a new provider type, there's the initial offer that Congress makes, and then there's the modifications that come to it down the line. And so I think this is sort of offer one, and we'll see what the uptake is on it, and then we'll go forward from there. The other opportunity is CMS is getting to review all the grants it has for a new community hospital and rural transformation payment model they're offering that would look at moving to more of like a global budget. And if that works in that context, is that going to be offered up in a broader way? And then what does that mean for the rural healthcare delivery system? So none of this may affect health centers directly, but it will affect the environment in which you're operating on. That's why I wanted to touch on it briefly. Next slide, please. And then the last area, as I was listening to Jim and Louise talk, we've had a range of community health funding for years through our rural health outreach programs, and then more recently, a targeted opioid program, the Rural Community Opioids Response Initiative. I've been really pleased that health centers have really leveraged this funding and been very creative about it. But to speak to Louise's point earlier, as you're thinking about, what can we do to create training networks? Because I do believe in rural communities, the more we can work together, that hospitals can work with community health centers and other providers in the area, because there's just such limited infrastructure there and such a hard time attracting clinicians to the point that they could work together on this. I think the community would be better served. Our grant funding, at least in our rural health outreach line, can be a way to do that. We offer both planning grants every year, and then rural health outreach grants and quality improvement grants and network grants. All of that, health centers have been really good at leveraging, but I think there's more that can be done there, particularly in the workforce area. It's probably the smallest percentage of applicants we get are those that focus solely on workforce. And so maybe there's opportunities to do more in there. And certainly we're going to continue to offer the opioid funding, and that is very flexible funding. And so that may be an opportunity too, to address the ongoing challenges, around substance use disorder and those sort of things. So with that, I'll stop there and just thank you again for the opportunity to be part of the panel and to talk to you today. Thank you, Don.
Thanks to all three of our panelists. We have a few minutes for questions. I think if I stop sharing my screen, I can get to the chat and see what some of the questions are. And one of the first ones is HRSA considering hybrid telehealth visits whereby appropriately trained and technologically assisted members of the treatment team visit the patient in their home or other non-office setting and are partnered with an office-based clinician who engages with the patient? Anybody want to jump in on that one?
Well, I'll probably defer to Jim on what that looks like in a health center context, but I think I think the approach of taking it to the patient always makes sense. It's the larger issue is, does the reimbursement model allow it in a way that's sustainable? I think that would certainly work best for isolated patients and folks with mobility issues. But if as we know from everything, if you can't pay for it, it makes it hard to sustain it.
Jim or Luis, you want to jump in on that?
From a workforce perspective, we're providing funding to support the education and training of the workforce. I think the delivery models is really up to the health centers. I think Jim could probably speak a little bit more about that. We certainly are going to continue to look at our funding opportunities where we can, and we have the opportunity to support our academic partners or anyone who's providing training in the workforce around the use of technology. Whether it's from your home to that office, to whether it's from an office to a patient's home, or you're in that home to somewhere else. I really think that question is more related to what is the delivery model that's going to come out of this as a result of everything that's happened around COVID.
Yeah, I'm sorry, I couldn't get off mute. One of the joys of being in Zoom and still not, after many months, learning how to do all of that. I think Louise and Tom are both right. It really is going to be driven by what patients and providers want. The one challenge that I will admit that we have sometimes is the limits of our statute related to telehealth. I know Louise and I have talked a great deal about that in terms of how far can we push the envelope. I think the COVID crisis has, of course, pushed all of us out of our comfort zone, and there have been a lot of restrictions that previously were in place have been removed, which is great. But that's part of the reason why we wanted to have this sort of new way of looking at funding for us in this quality improvement, optimizing virtual care approach to really test out what kind of models make sense. The idea of providing care in home makes a lot of sense. In fact, I was just reading an article yesterday about that hospitals are starting to look at a similar approach in terms of how can they provide hospital care in a patient's home. And so I think a lot of the boundaries that have previously been in place and really facility driven really are going to become different. One of the things that we've sort of honestly blown the mind up of our OGC colleagues has been creating like virtual health centers, where literally like you have a health center site that is all virtual, where basically it's just people providing virtual healthcare services. And they're still trying to get their arms around what that looks like. But I do think, whether that's in a current site or someplace else is something for the future. And, providers providing care at home, patients receiving care at home, virtual care. We talked a lot about access to specialists. We don't have the answers yet in terms of like what this looks like, but I do think, being driven by what the patients want, the experience that we've had will allow us to have some conversations that we honestly weren't able to have beforehand. So it's exciting. And I know it's going to be a little disconcerting to certain folks. So.
Going to shift gears a little bit with another question that says, has BHW considered funding apprenticeship programs in health centers?
We have, and we fund apprenticeship programs now. And this is, I saw that in the chat, and I just, I think this is an indication of making sure that we're sharing the funding opportunities with our partners and they understand what's available and what's not. And again, we have released funding to support in the area of behavioral health paraprofessionals, and the last funding opportunity included direct funding support for apprenticeship programs. So we're next week, I believe we're having our Northwest PCA regional meeting where we're going to talk all about our behavioral health workforce programs. I encourage everyone to chime in on that to learn a little bit more about those investments. So we do see apprenticeships as a viable means. They're successful. We're partnering with the Department of Labor to support their certified apprenticeship programs. We have a technical assistance that's providing support to all our awardees right now through that funding opportunity. So we're big fans of apprenticeship programs, and I'd like to see more of them in health centers. And so I think that's probably a future discussion with Jim as well. How would that happen?
Jim or Tom want to jump in, or is Luis? I think we have time maybe for one more question. And I'm not sure which one to pick, but it looks like one of the questions was, is PCAs operate at a disadvantage because they don't have access to the BHW portal? Is it possible to, and maybe that already happens too, Luis, perhaps you could respond to that.
No, well, I think they've identified a gap here. We currently have, for those who know, a PCO, Primary Care Organization Cooperative Agreement, that allows them access to that portal. So that's the main reason why they have access to it and PCAs don't have that level of access, because we need PCOs to have access to that portal to increase that data, to submit that data. But I'd like to take a look back at that and talk with our teams. What are our available flexibilities that will allow greater insight into the portal? I think another question there, Don, related to PCAs, is someone asked a question about virtual job fairs. And most certainly, we can support PCAs in their efforts to recruit staff into health centers through our use of our virtual job fairs. And that's one thing that I want to take back to our team to engage with the PCA leadership on, okay, how would that happen? Because we've done this for IHS, we've done this for behavioral health, we've done this for rural, and I think we can certainly do this for PCAs in particular.
And if I could, Don, I think, and I've seen a lot of the questions, I think one of the things that I think all of us are really trying to work through is, how can we support our staff in the best ways possible, but at the same time, make sure that we're meeting the needs of our patients, and what's that balancing act in terms of what that looks like, because we need both. We need patients and we need staff. And so what's that right balance in terms of supporting them? And I think the whole issues of health equity and diversity are absolutely essential if we're going to meet those needs. And so really thank you all for holding today's panel, and more importantly, the next several hours of workshops that you guys are working on to help us think a little bit more clearly, but hopefully also you all in terms of what we can do at all levels to support this work.
Well, I think I speak on behalf of all of the participants, and I know there's a few questions we didn't get to, but we'll get those questions out to everybody and get answers back to you all. Thanks to Luis and Jim and Tom, not only for what you've done today, but for what you do each and every day to make a difference in the health of underserved communities and working with us and for those communities. So thank you on behalf of all of us. And I think I turn this, we can do this. I actually can do this without the, and Gerard, I'll turn it back to you.